move into our panel discussions, and just wait till everybody settles here. As Mike mentioned before, we have 4 different topics to go on there. Well, one of them will be up there. So, John might as well stand up and leave some room since you're first. So we're going to have Dr. John Breyer to speak first about the Emergency Department Mental Health Access Project. John is the Emergency Department lead for the Southwest LHIN, and he's also past chair of the OMA section of emergency medicine and a former chief of emerge at LHIN Health Science Center. And he now is working along with doing research as the director of Western's University Division of Emergency Medicine. He also works at 4 counties, Hospital in Newbury as the chief of staff.
And if anybody wants to offer me another job, I'm always looking for something to do on the side. So thank you very much for that introduction. And see if I can, is it the red button? No, the right button. Okay. So what I'm going to spend a few minutes talking about and this evening is just a small project that we're working on in terms of getting better access for patients with mental health conditions across the LHIN. We noticed in our travels around the LHIN, and I say we, meaning myself and Bob Barad, who is the project lead for emergency departments in the LHIN. He's my administrative right arm. When we went and talked to physicians in a number of emergency departments, and we have 27 in this LHIN, we didn't get to all of them, but we got to all of the alliances. We were told over and over again that their #1 difficulty in terms of getting patients access to care was mental health patients. There are a number of Schedule 1 facilities. There are 6 in our LHIN. And as you probably know, patients can really only receive inpatient psychiatric care at those Schedule 1 facilities. So for the other 21 emergency departments, sometimes it's taking up to 72 hours to get patients access to care, meaning get them to the Schedule 1 facility. And as you probably also know, Form 1, which are those are the patients we're talking about, the Form 1 only lasts for 72 hours. So we're getting very close to the line with some of our delayed transfers. So it's a somewhat complex issue in terms of getting them to definitive care. They have to be assessed first in wherever they show up for their care, whichever emergency department they're in. Then they get referred, they have to be accepted and assessed, disposition, and ultimately, if they're admitted there, then ultimately get repatriated. So that system isn't as optimal as it should be. It's quite inconsistent across the region and often results in significant delays. The non-Schedule 1 emergency departments in the region really are not equipped to look after these patients. The staff aren't trained, they don't have the physical facilities, and very often they certainly don't have security staff. Very often they rely on local police or the OPP to come and guard some of these patients when they're more violent and a risk to themselves or to others. So our LHIN, as you probably are all well aware, is quite large. It's not as large as the Northwest LHIN, but it's big enough. It's about 21,000 square kilometers. I think we have 7 counties within the LHIN, population of about 1 million people. And as I said before, there are 27 emergency departments, and our Schedule 1s are in Owen Sound, Goderich, Stratford, London, Woodstock, and St. Thomas. So we decided that this was a big enough of an issue that we would try to get some buy-in from the CEOs in the LHIN, the hospital CEOs. We presented this project to them at their leadership forum. And then our request was to get their support to form a working group. The working group is made up, chaired by Andrew Williams, who's the CEO of the Huron Perth Hospital Alliance. He's the champion for us And then we have representation from 2 of the Schedule 1s. We have Jeff Reese, who's here tonight from LHSC, and his right arm, Catherine Glover, who's the manager of the mental health program at LHSC. Dr. Rafiq is a psychiatrist from Grey Bruce, and Leah Hood is his right arm. And then together with them and Bob Durad and myself, we've had a small working group, met a number of times. The goal is to have all Form 1 patients referred to Schedule 1 and get their assessment and the disposition all within 12 hours. So 12 hours is a lot longer than I'd like it to be, but I think it's a reasonable first step. Wait times for some of these patients have been quite long, as I referred to in the up to 72 hours or almost 72 hours. But none of this data is very accurately collected. We have individual sort of anecdotes of patients that have waited long times. So nowhere in the provinces is being collected. Our Schedule 1 facilities have agreed to start tracking this as of the 3rd quarter of the current fiscal year. And we're actually looking to model ourselves sort of along the lines of what is going on in the Champlain LHIN, where they have a centralized on-call psychiatry service. If you're in a small hospital like Winchester, south of Ottawa, and a patient comes in, is put on a Form 1 by the emergency physician there. They call up to Ottawa, they speak to the on-call psychiatrist, who then determines where the beds are available and where that patient should be sent. And I believe, I'm not that familiar with the system, but I believe there are basically 2 sites in Ottawa that accept the patients. And so they sort of alternate for the area right around Ottawa. So the metrics that we're going to collect over the coming months are the time that a Form 1 was initiated, the time from referral to assessment by a mental health professional, time from decision to admit to it actually getting into a bed, the number of patients that were put on a Form 1 who were referred, and the percentage of patients who were put on a Form 1 who actually ended up being admitted. Because there may be, as there are with many referrals, a number of patients, and we know there are a lot of patients who ultimately are discharged by the mental health professional. And is there a way, in fact, to prevent that up front? And we may be able to look at things like using telemental health, where the psychiatrist would be able to actually see the patient in the small hospital and determine whether or not they actually need to go at all, or whether adequate follow-up could be put in place that would prevent the patient from coming to a grisly end. So currently, mental health patients are not in scope for critical or the one number process, although this is being done in the Champlain LHIN. So again, those calls are handled by critical, but it's our understanding that mental health is going to be included in the one number system in the near future. The ministry has already put out a call for proposals for development of a provincial bed board, and in fact they have awarded the contract, as it were, to Critical to do this. As of last week, Critical was still waiting for the funding letter. They've been waiting since August, I think. So hopefully that will come soon, and it'll move our little project, help move our little project along a little faster. So I'm going to end at that point. I'd be happy to answer any questions now, or Gord, if you'd like to just go on to the next presentation, and we can have questions at the end.
Thanks, John. There will be time for some questions afterwards. Just want to make sure we at least get through our agenda without being too far behind. So next up, we're going to have Dr. Rob McFadden speak, and we're going to look at a little bit at some of the technological improvements that sort of play a crucial role in patient access and flow. And Dr. McFadden, he has been at St. Joe's Hospital for a number of years, and now he's the chief of respirology and the hospital chief of medicine.
And in Champlain, for instance, I know that teledermatology is a big part of the program in ophthalmology, with taking pictures of patients' retina and other things, sending it to specialists. It's going to be a little bit different in the Southwest LHIN when it gets started. But basically, we are looking not really to facilitate consults that we need to see, but avoid consults we don't need to see but can help with electronically. In my discipline of respirology, one of the most common causes now is a referral for an abnormality on CT that came up as an incidental finding. And we are flooded with patients like that, such that our waiting lists are growing, and why it's sometimes hard for us to see patients. Each specialty has identified a few of those scenarios where we think we could avoid seeing the patient directly, guide ongoing management, either in primary care or refer them to the right place where they would be dealt with expeditiously. Oh my God, look at that slide. So here are some of the hypothetical benefits of eConsult service. And as I say, if we, how is this about access and flow? Well, obviously we can unload patients that we don't need to see in our clinics. Some of them wait months, as you're well aware. Then perhaps we can be more expeditiously following the patients we need to see in person. So the key objectives, we've got lots of things we're going to look at, including reduced wait times. It's a little bit of an oblique thing because we wouldn't actually never see the patient, not always. Sometimes we wouldn't be able to avoid it, but we would be able to hopefully get them to the right place. And what will be the benefits? And I'm still not sure about that. We haven't started our pilot yet, and I can see in the scenario I mentioned about the patient who's been told they have a spot in their lung, is it going to be a benefit to the patient? Will they feel better that I answer the family doctor in 2 days with a recommendation, or are they going to be satisfied with that? They want to see the specialist who they would probably wait 4 months to see, which is, you can imagine the angst that no longer have. So here, it was mentioned earlier, several partners beyond the Champlain group at the top are going to be engaged, and down at number 5, Southwest LHIN, both London-based hospitals. Specialists will be involved in this, and I'll show you a spectrum of the specialists in a second. And this is part 1, or phase 1 of a plan. So just the group on the last slide are going to begin with. Stephen Wetmore is the primary care lead in the LHIN as well, and he has engaged 50+ family physicians to start on this pilot. And I'll show you a list of the specialists in a minute or two. And then their decision is going to be made centrally by the government, by the various groups involved. All of this run through OTN for the first phase, about whether this is something that we want to roll out to the whole province. So most of the people in this room will not be engaged in this pilot to start with. Some of us will be. And then it's going to be decided. Quite honestly, I can't see avoiding something like this in the long run. Hopefully there's some important learnings we get from phase 1 of the pilot, or the pilot project itself, and we can learn how to do this better. None of us are entirely sure how this is going to work out, although apparently it's working very well in Champlain. So, in scope, we talked about the regions that are involved. There's not going to be every family physician being able to hook up to this at the present stage. And obviously, we also have a third-party vendor who is working on a benefits evaluation. How do we evaluate this from the primary care perspective, from the specialist perspective? For phase 1, we won't really be able to get into what the patient's perspective is, although I think that's fruitful work for research in the next phase. Out of scope, obviously, we're not currently going to integrate this with everybody's EHR. That's an impossible task at present. Again, a complicated slide looking at the structure, and obviously Ontario MD has a leading role. There's a steering committee, and we are on a provincial advisory group that advises about how this is rolled out. And just to give you a local flavor, this is an updated slide on specialists. The numbers in brackets is we have 3 distinct vascular surgeons who have agreed to go into the trial. And this actually, you may be missing a couple of specialists that have expressed interest. Pediatrics has been lately added to the list. And renal calculi is actually urology, in case you couldn't figure that out. So that's all I have to say about eConsults. I think it's a fabulous opportunity. We've just been notified that the project we thought that was going to start this month is perhaps going to be delayed a couple months, but hopefully we'll have time to show the benefits of this. Thank you for your attention.
Thank you, Rob. So next up, we have here Dr. Sharp. And Dr. Sharp is the critical care lead for the Southwest LHIN. He's also practicing full-time in critical care medicine and is an active researcher and teacher. He has held the position of the Associate Scientist at the Lawson Health Research Institute in London. And he's the chair of the Organ Donor Management Committee of the London Health Science Centre, a member of the Provincial Organ Tissue Transplantation Wait Time Expert Panel, and the Transplantation Action Team. Well, there's probably an acronym for that. So, anyways, we'll let John talk about the critical care and flow initiative.
I only had 10 minutes, so let's keep it short. Some of these slides I'm going to go through quickly, some I'm going to miss. For the benefit of our special speaker this evening, Jeff Turnbull from the Ottawa region, some of the slides are in French, so I'm going to pass those on. Okay? Okay. I realize that the number of critical ill patients in our LHIN across the province is a very, very small number compared to the number of patients that you are dealing with. Dealing with access to mental health, having patients have primary care doctors. I mean, these are huge and important problems, because you know what? At the end of the day, if these patients don't get these services, guess where they end up? With us. These are our sickest patients, okay? We talk about equitable access. The bottom line is, if you're going to have your heart attack that requires cardiac intervention, whatever that is, would you rather have it up in Tobermory, or do you want to have it in front of the emergency room in the London Health Sciences Centre? I think the answer to that is straightforward. The bottom line is, our responsibility as critical care physicians is we try and make that access as equitable as possible so that we improve outcomes as best we can with our sickest patients across the province. So that's our responsibility, and that's our accountability. Now, this all started, it's a three-tiered thing. It all started with the one-number program that started within LHSC, is now spread throughout our LHIN as well as neighboring LHINs. This is a phenomenal program. Basically, it defines acuity of illness of all patients, of all disciplines, required needs, okay? And they distributed these patients according to their acuity of illness and how soon they needed intervention. And of course, the patient that required intervention between 0 and 4 hours is our sickest patients. Those are our patients. So we came immediately involved in determining how can we define these patients, how do we recognize these patients, and what is the process to give them the care they need. There's only one reason why patients, a critically ill patient, needs to be transported across this province. Only one reason. And that is where they are, their care needs exceeds the capabilities of where they are. And that's the only reason these patients need to be transported. So, second to that came the Life or Limb no refusal policy, and recently the EXPRO projects. The Life or Limb project and the EXPRO projects were projects that were initiated within the Southwest LHIN with the support of the Southwest LHIN program, and without their support, these projects could not have been completed. So kudos to them for believing in what we thought was an important initiatives. This is a one-number protocol. I think you're all aware. I don't need to spend a lot of time in this. Basically recognizing what services these patients need and how quickly they need to get those services. Life or limb policy. This is if you have a life or limb diagnosis that needs intervention within 4 hours, failing that will either cause loss of life or limb, then that's considered a life or limb. This was initiated in the Southwest LHIN. And basically it told us if you have a life or limb problem and you call us for that problem, we couldn't say no. We can't say, oh, we're full. We can't say we're filling our rest bed. That language has now disappeared. This program was extremely successful, and I give kudos to London Health Sciences Centre and our critical care team, the nurses and everyone, because we couldn't say no. In fact, word got around that everybody called London because they don't say no. And that's a bad thing to do. So we said, this has to be province-wide. And sure enough, this became so successful that this was implemented in January this year. So it's a tremendous program, recognizes our sickest patients, And we can't say, I'm sorry, we don't have an ICU bed, we can't take you. We do take you, and we do our best in terms of developing a bed and access to this patient. So our responsibilities are, if we're paged through the one-number system, and there's a doctor calling with a life-or-limb patient, our responsibility is to answer that page, which is notated by 999 within 10 minutes. We often have family physicians out in the communities dealing with the sickest patients they've ever seen. They rarely see these patients. They need help. They need support. They need advice. So our responsibility is to get on that line and start talking to that individual person. You know what happened before? What happened to these patients? They're put in an ambulance and they end up in our emergency room at London Health Sciences Center. Now we have a coordinated effort with many people on the phone giving advice, which is the proper care of this patient. We don't like to go down to an emergency anymore. We do our best to bypass emerge and get patients directly into our intensive care units. They're grouchy down there. We don't want to do No. This really looks at the volume of life-or-limb cases now across the province. We're looking at these cases extremely carefully. We're modifying the program. Basically what we're doing is increasing the efficiency of dealing with our sickest patients. Now, the extramural program. Our difficulty in London was, if I'm on call, I used to get these calls from critical with a life-or-limb patient. That's the last thing I wanted, because I'm dealing with sickest patients in my intensive care unit. I didn't want to have to get on the phone, particularly during rounds, when there's 25 people sitting at the table. So we now developed an extramural program, which is an ICU physician on call to take these calls 24/7. We do not have any responsibilities in the intensive care unit. So we do answer the phone in 10 minutes. And that's exactly what you need to help give you help in the community. And it allows collaboration also between our ICUs within our Southwest LHIN. I consider all the level 3 ICUs that can ventilate patients, one ICU in our Southwest LHIN. We're not an ICU. The entire Southwest LHIN is one ICU. And if we get a call from the community hospital that can be cared for in a similar level 3 ICU as close to them or near them, then we will call that ICU and see if they can take the patient. We don't have to take all these patients. We can't. We want to take the patients that no one else can. So neurosurgery, cardiac surgery, and so on. So we try and spread the wealth to neighboring ICUs. At the same time, we're educating these ICUs with education for ICU nurses, as well as the trainees that are leaving our program are now going out in the community and working in these ICUs, so we're ramping up the capability and efficiencies of these ICUs as well. So it's a collaboration between our hospitals, our alliances in the Southwest LHIN, and really it's been a lot of fun. And I think that has resulted in tremendous improvement in access to critically ill patients. Average response time for hospitals that are LHIN, you can see the LHIN average is the yellow bar, the green is the provincial average. London Health Sciences is at about just at 10 minutes, and that's what we want. The reason we're higher than some other places across the province, we have the one-number system. It takes time, right? Critical calls one number calls us. If they need a neurosurgeon, they're also calling the neurosurgery. If they need HULK, upper limb, we're calling the upper limb at the same time. They're all on the same phone call together. Very efficient process. We decide what needs to be done to this patient and where they need to go in London, if they need to come. Oftentimes, we transfer that patient to our hospital. That's what we need to do. But the bottom line is the average accept time. You can see that London Health Sciences Center, although we have 2 minutes, thanks. Although we have 10 minutes of 10 minutes of response time, we have the lowest accept time in the province. In other words, we define that this patient needs to come to us or go to a specific other ICU, and we make that decision in less than 30 minutes. That's tremendous. All right, busy slide. The only thing I want you to see is this. 2012-13, 2013-14. This is the number of cases of one number intake, 2,700, 2,900. The brown is the number of cases that come to our emergency room. That's coming down. The black is the number of cases coming directly admitted to our hospital. It's coming down. So we're keeping patients where they should be out in the community and getting the support and care they need in the community. Whereas before, they used to land in our emergency rooms. Satisfaction, the bottleneck. I took a 3-year course in making slides, and this is we have a bottleneck. We're getting all these patients in, we need to get them out. Level 3 ICUs, particularly LHSC, high level of acuity of illness. We have a large geographical catchment area that we have to take patients from. We have the highest number of delayed discharge days in the province. We can't get our patients out. Some of them need some of them need to go to step-down unit, some need to go to the ward. I've discharged more patients home from our ICU this year than I have in my 20 years of practice. That's what it's all about. We have the highest number of nighttime ICU discharges in the province. That means the readmission rates are going to be higher. You don't want to be discharged at night. You want to be discharged during the day. Outcomes are worse if you're discharged at night. We have no choice. And we also have a significant number of ICU beds consumed by chronic bed patients. We are working towards that with some nice initiatives which started in Southwest LHIN again and again across the province. Repatriation, this is huge for us. If we feel that we have patients that can be repatriated back to the home hospitals, the first and foremost thing we determine is this hospital can't take care of that patient. We're not going to send anybody out to someone who can't care that or uncomfortable or cannot care for that patient. So repatriation is huge and very important. What is working well? We've all seen this. Here are the challenges. Well, all repatriates go well. Patients don't want to go back to their home hospitals. We want to be here. We're safe here. This is a problem. Some physicians do not want the added burden of caring these patients. We've seen that. Specific patient populations require additional resources that may or may not be available in the community. We need to deal with this. Caring for individuals due to expertise, capability of diagnoses that are cared for in few situations, such as our place has epilepticus. And transitioning chronic ventilated patients is a huge undertaking. It's important, small number of patients, but they consume a horrendous number of ICU bed days. These are patients that can be cared for in the community, and we need to develop the infrastructure in the community to take care of these patients. Opportunities, we want to be part of the solution, not the problem, and I think we're quite evident of that. We need to change from a pushing these patients out in the community to a pull community. We have hospitals that are phenomenal. Say, as soon as your patient is ready, we want them back. Call us up and we'll take them back. That's what we need. Scorecards. We have a responsibility and accountability to improve our quality, as Jeff mentioned. These are the scorecards that we're now developing for ICUs. If you're not doing a good job, smarten up, and we'll have to make changes. Critical care system integration. This is the roadmap for critical care across Ontario. You can see, long-term ventilation is there, pediatric repatriation, trauma and burns, life preventive, neurosurgery and spine. That's where we're going, and I want to assure you that when you have your sick patient, that we will take care of your patient for you in an efficient and expeditious manner. Thanks.
Thanks. So our last panel speaker tonight is a bit of a tag team here. We have Donna Lennesur from the Southwest CCAC and Dr. Scott McKay. So Donna is a nurse who spent a number of years working with acute care patients, and then she worked in pharmaceutical research for a number of years, and now is the Senior Director of Client Services with the Southwest CCAC. She's also been strategically involved with the Hospice Palliative Care for the last 15 years, and is the co-chair of the Southwest Hospice Palliative Care Leadership Committee. Dr. McKay is one of the primary care leads for the Southwest LHIN. He's been a family physician at the Byron Family Medical Center, and he's the attending physician at Dearness Long-Term Care Home since 2008. Prior to working in London, he worked in family practice in emergent Sarnia, And Scott has also earned his Master's Certificate in Physician Leadership from the York University Schulich School of Business and Excellent Education. So they're going to talk to us together about the area of discharge planning.
Thanks, Lord. So I think as we've heard from our other speakers, I mean, keeping access and flow going to our hospitals is a critical part for our patient journeys. A very short time of our patient journey often is spent in hospital. So what we need to do is focus on that discharge as early as possible in the patient's journey when they come to hospital. And so we can have those critical care beds available for patients. We need to ensure that the patients are flowing through that system quickly. And one of the tremendous successes has been the Access to Care initiative that's been supported robustly over the past several years by our LHIN partners. And one of the key focuses of that was Home First. And many of you in this room have heard of Home First. The purpose of Home First sounds very simple, but it is. As soon as the patient arrives in the emergency department, we start talking about getting them back home. The first words out of people's mouths isn't, well, it's now time for you to go to long-term care. Once you start that conversation, you're dead in the water. You're never going to get them to move. What Home First is, it's about having those community resources available to support the patients in a more robust way. What we found is patients that are going home with the Home First approach to care are patients that 3 or 4 years ago would have remained in hospital as ALC. And a critical part of connecting those patients to get home is that engagement and active, proactive engagement with the primary care team, because you're the team that's going to catch those people once we get them home. But the success of Home First, I think, as I look at some of the ALC numbers, is truly about moving the patients through. And I was talking to Carol Young-Ritchie when I came in. The ALC at LHSC is right now at 66, and that includes 10 that are mental health clients. A few years ago, that would have been in excess of 100 at any given time. So we are moving the people through. We need to keep at it, but it is moving people through. And what we looked at is we want to do that consistently across all of the hospitals in the Southwest. We started with LHSC, but how do we ensure that all the hospitals are approaching patients in the same way? So the chief nursing executives across all of the hospitals and CCAC work together to collaboratively develop a toolkit that gives guidance and scripts and policies about how do we ensure that we're all adopting this process. Some of the hospitals are have this fully implemented, but the goal is to have all of the hospitals to have this toolkit implemented by March of 2015. So Scott's going to talk about some of the other initiatives that are going on in this area around discharge planning, but it truly is that collaboration between the hospital, the community partners, and the primary care teams to be able to keep these moving forward.
Thanks. So what I wanted to highlight tonight was just a few of the things that are happening, to tell you about some of the work that's either about to get underway or is going to be underway, that hopefully may touch many of you in the audience to get involved or give your feedback. And I know we have to get on to our discussion, which is really going to be the most important part of tonight. So I will keep it brief. So the ideas, there's several ideas projects that are happening within the London Middlesex area. So St. Thomas Elgin General Hospital has a discharge planning project that's looking at the discharge planning process and how it can be improved to make sure that the communication happens, that the follow-up happens, that's looking at specialist follow-ups, looking at patients that are being discharged to long-term care, and how that process, where the gaps are and how it can be improved. LHSC has an ideas project that's been approved, another one that's in the queue that hopefully will be approved. One's looking at COPD patients and making sure that they all have a care plan when they're discharged, of exactly what their care plan is going to look like when they're discharged, who's going to support them in the community, how they're going to follow up with primary care and their specialists, that coordinated care plan idea that HealthLinks is going to bring to us. As well as we've just submitted last week, a project that I'm involved with is looking really specifically at how for medicine patients we can get discharge summaries to primary care within 48 hours. Because this is something that, it seems like it's an easy, potentially easy problem to fix. Consistently, this is what I hear, and this is what I experience as a primary care provider. That especially for those most complicated patients, it's maybe half the time that I have the information at my fingertips when I need it, and that's something that this project is going to specifically look at. There's also a few things within LHSC internal projects. We're looking at a continuity of care Kaizen. There's a big push for Toyota production systems within LHSC right now, and that's looking at how all the pieces, continuity from a merge to the inpatient to the outpatient to community is really going to work together where the gaps are to improve that, as well as there's another project happening, the Connecting Care Collaborative, and this is something specifically that the family medical centers associated with the hospitals are looking at, how to improve the gaps in the patients with the highest needs with CHF and COPD, and then what's going to come out of that hopefully is a lot that will go into health links and actually go out to the whole community when we can get the house within LHSC in order, how we can roll out to the community. Telehome care is something else that's on the horizon. My understanding that's going to be rolled out for COPD and likely CHF patients first, so that's where connecting with our patients in more rural communities and helping them get that follow-up that they need after a discharge and making sure that information is where it needs to be. So I think I'll leave it there. There's lots of exciting things happening with discharge planning. So I'd actually invite anyone that if you have comments or questions or feedback on how discharge planning can be better, please connect with me afterwards offline because there's a lot of projects that we can bring your feedback into as we shape what discharge planning is going to look like.